Next speaker, Dr. Amr Kamal, Professor of Cardiology at Alexandria University. Device treatment of HFrEF. قدامك دقيقة وربع.
مساء الخير. طبعا يعني الموضوع ده موضوع كبير جدا وانا I will go through it very quickly. Apart from the device therapy in reduced heart failure, as we all know, there is positive trials to the drug therapies for the HFrEF, but still the residual risk is high. And this underscores the need of continued development of innovative treatments on heart failure. I will show you some magic, but it is currently is in the progress phase. We all know that ICD and CRT in heart failure is well established as a class 1 level of evidence A or B for ejection fraction less than or equal to 30%, and NIHA class 2 to 3, or even class 1 symptomatic despite receiving medical therapy is indicated for ICD to prevent sudden cardiac death. And CRT is, of course, well known for a left bundle branch block of a duration more than or equal to 150 milliseconds with NIHA class 2, 3, or ambulatory 4 with medical treatment. This is well known and it is proven in the guidelines. What's new? The new is the FDA approved therapies, the TER, the PAT, the CCM, and other interventions for heart failure. First, the valve therapies. To treat mitral regurg, we have the MitraClip device, and it is, of course, approved for primary mitral regurg, and for secondary mitral regurg 2 years ago in the COAPT trial, in the TCT, proved that it is important for patients with secondary mitral regurg. Other devices like the Pascal device is also developed for treatment of edge-to-edge mitral regurgitation reduction. This is the device of MitraClip and how it treats the mitral regurg. Then this is the Pascal and how it clips the mitral leaflets, trying to limit the mitral regurg. Then we have the transcatheter mitral valve replacement to treat the mitral regurg. We have two components, either the Intrepid system or the Tendyne system. The Intrepid system is a self-expanding dual frame valve with a circular outer fixation frame, while the Tendyne is a bioprothesis with a repositioning and retrievable system, and there is an ongoing summit trial for those transcatheter mitral valve replacement. This is how it looks. On the left is the Intrepid, and on the right side, the D-shaped outer stent with tri-leaflet valve is the Tendyne mitral valve replacement by the catheter. Then the innovation is continued by reshaping of the failing left ventricle from outside, from the coronary sinus. We know that the coronary sinus is encirculating the mitral annulus from outside. Then it comes the carry-on mitral contour system. This carry-on is indirect percutaneous device placed in the CS to cinch and reduce the mitral annular diameter. There is the reduced FMR trial and the ongoing carry-on trial. This is how it looks by introduction inside the coronary sinus and doing the anchoring, the distal and proximal anchoring system. And it's very easy. We can cinch the mitral annulus to reduce the mitral regurg in the secondary mitral regurg. This is a case how it looks by putting the catheter, quadripolar catheter in the CS and the then we put the anchors, then we fix it and stretch. The stretched mitral annulus is reduced and reduction of mitral regurg occurs in the left ventricular systolic function. The 12 months follow-up showed reduction of mitral regurg, reduction of the left ventricular endostolic volumes and end-systolic volumes. Then it comes a new innovation by reshaping the failing left ventricle from the inside, not from outside, from inside. We have this V-sling. It's just shown in the last TCT by George Stone. And this is how the 18 French should go transaortic to do a V-sling by tethering the papillary muscles together, then clinching on the mitral leaflets to reduce the mitral regurgitation and to reshape the left ventricle from inside. Also, there is a fantastic system which is the AccuCinch, ventricular restoration system, by putting this device circular cinching of the papillary muscles and chordae to decrease the left ventricular dimensions, the left ventricular wall stress, and it's of course a very effective one, innovative treatment that is still under investigation. This is how it is done: transaortic access, delivery, then cinching to reduce the left ventricular dimensions. Then what about the autonomic modulation? We have the BAT, which is the baroreflex activation system. We know that the baroreflex is disorganized and dysregulated in heart failure because of a stretch. Then if we put a device that stimulates the baroreceptors, we can regulate this by decreasing the sympathetic overtone and increasing the parasympathetic tone, leading to slowing of heart rate, improvement of heart failure, and vasodilatation and increase in the renal blood flow. Then another innovation by stimulation of the vagus. The vagus, if it is stimulated, the hypothesis that we will increase the parasympathetic flow, decrease the sympathetic flow, decrease the oxygen consumption, improve the ventricular remodeling, and decrease the heart rate and afterload. This is how it acts, by percutaneous device that is connected to the vagus and leading to that. Splenic nerve block is another modality that can be used to redistribute the splanchnic area by decreasing the splanchnic vascular tone and decrease the sympathetic tone that can accommodate the blood with volume redistribution in the abdominal compartment rather than in the chest. The cardiac contractility modulation is another way that can be used by increasing the intracellular calcium by the optimizer system, delivering a biphasic long duration high voltage signal to the septum during absolute refractory period, leading to stimulation of myocardial contraction, and this was shown in the fixed heart failure 5C trial, and this how it can act. Electrical microcurrent therapy, the same idea. Then respiratory modulation by doing the phrenic nerve stimulation to improve the central sleep apnea in patients with heart failure by improving the diaphragm pulling into the lungs, and how it improve the respiration in patients regardless of the ejection fraction. The same idea with asymptomatic diaphragmatic stimulation by the VIS-1 asymptomatic diaphragmatic stimulation system that deliver diaphragmatic stimulation pulses at asymptomatic outputs gated with the cardiac cycles. It's actually an amazing idea. What about structural interventions? Interatrial shunting. Exercise induced in the left atrial pressure and filling pressure, the CWBW, can be dampened by this interatrial shunts that has a perforation to shunt the blood during exercise and improve exercise capacity and PVO2 consumption. Either the volume management can be regulated by device, by the peritoneal direct sodium removal that uses a non-renal approach to prevent and treat volume overload using a zero sodium peritoneal solution rather than peritoneal dialysis, and improve the balance between the extracellular fluid and solution. So summary of evidence. The following FDA-approved devices-based therapies may be considered in patients with HFrEF if ejection fraction 20 to 50% with moderate to severe mitral regurg and end-systolic dimensions of more than 7 centimeters, NIHA class 2 to 4, despite maximally tolerated guideline-directed medical therapy and CRT is appropriate. Mitral clip implantation is a 2A consideration in these patients. For those patients, 25 to 45% ejection fraction and QRS duration less than 130, NIHA 3 to 4, despite maximally tolerated medical therapy a cardiac contractility modulation therapy is 2A therapy. And for those patients less than 35% NIHA class 2 to 3, despite maximally tolerated medical therapy, BAT or barostim optimizer system is considered. And in patients with moderate to severe central sleep apnea, regardless of the ejection fraction, phrenic nerve stimulation may be considered. Thank you so much. Thank you.
بروفيسور دكتور
هو
عمرو.
يعني كلام شوية ممكن يبقى غريب ان احنا نسمعه، بس this is what is happening now in medicine, that we have to treat patients with heart failure with drugs and the residual risk with devices. The devices is based on understanding how the heart failure is زي ما دكتور أحمد قال الphenotypes of different patients with heart failure. So if you know the mechanism and pathophysiology, you